There's not, yes.
Question, Dr. Campbell. I appreciate your presentation. It's very, very interesting. Have the regional mental health task forces across the province embraced this concept of tele-psychiatry? I know they're looking at all avenues of service delivery. Can you speak to that?
Excellent point. They are going to be entertaining. As a matter of fact, the OPOP group and the universities are going to present it to each of those task forces. It is important. They are aware. I presented what we were doing at Western to the regional task force there, and each of the others are going to be doing the same, so that there could be some coordination, so that they're aware of the value and aware of, especially considering if you have to download the psychiatric hospitals to the communities. You can't do it without a telemedicine component in place or telepsychiatry, because you can't follow them in the community. There's not enough psychiatrists to go around. So it is important for their planning. Very valuable point. We're not as far as we should be, but we are. We have a plan, and hopefully within the 2 or 3 weeks, the chairman of those task force are going to be will become brought up to date in terms of what our rollout plan is. Thanks.
One of the things that, after hearing Robbie talk about this a number of times, that interested me was, I think you're aware what happens if patients are up north or somewhere else, and Robbie meets them on a video link and has a psychiatric encounter with them. And I've talked to him a number of times. It's been amazing to me the degree of comfort you and apparently the patients feel with that type of interaction. Can you talk about that a little bit?
Yeah, there's what happened. I guess I always use the example that if a person is at a distance, they'll talk a little bit more. But I like to use the example of the schizophrenic patient. And we're always worried because they get paranoid and they think that the television's talking to them, and therefore we take them further into their delusional system. That hasn't happened. What happens is that people will focus on that telly. And that telly is sitting there. It's a little bit like watching Larry King. He becomes the authority. The psychiatrist becomes the authority. As a matter of fact, even presenting yourself on that telly gives you, sets you up to be a little more credible. Now, I realize through the television media that that's not the case, but that's how people interpret it that way. So their anxiety is lowered. As a matter of fact, when they fill out their patient satisfaction form, he put on there, I was able to talk about stuff I couldn't normally talk about with my psychiatrist being in that same room. So if anybody goes to visit a psychiatrist, there's a certain amount of anxiety that's escalated just by being in that room, by telling the story. If you're once removed, it's a little easier to tell that story. Sometimes on the telephone, sometimes on the video. But we as psychiatrists have to see somebody. We have to be able to follow their gesturing. We have to be able to follow some of those cues that we have. Now, I as a psychiatrist don't pretend to be able to interpret various cultures. So I would call in another psychiatrist with a telly from a different place if it were a culture that were foreign to me. I feel quite comfortable with the culture that I'm raised in, but once I get outside of that, I'm not so hot. And that's probably even the same with First Nation people too. We need to have their help.
I'm curious your reactions to that.
Yeah, well, I was just curious, like following up from that is like just the social engagement aspect of it, and that's one area that I'm quite interested in, and being able to discern like eye movements and subtle gestures, things that you might not be able to see otherwise, like my hands being like ringing or something that being in a place that you can't see. Is there someone else kind of in the room, kind of monitoring what's going on? Or, has there been any kind of experimentation with that, or kind of facilitating that, or kind of informing the person, like the doctor on the...
Yeah. I think you make an excellent point. And what we've done is that our insistence, my insistence, is having someone at the other end be the prime therapist with them. So they can pick up that gesturing, also give you the story from their perspective prior to the meeting, ensure that you have the data to you prior to the meeting, and that they sit with them through, unless there's a reason for them to say, could you excuse me for a few minutes to talk to, because it might involve somebody in that community. Right. So we say that's okay as long as that person comes back in. So we feel it's very important, as also from a Medical Protective Association, is that if I'm the psychiatrist here and something happens after that interview and they happen to go out and kill themselves, I can't be the most responsible person. So if I'm at a distance, if I'm here in town, I am the most responsible person. But at a distance, I'm helpless to do anything about it and can't make the connections fast enough, etc., and don't know that community. So I leave that in the hands of that community. They designate a most responsible person. So if it happens to be the nurse there, she reports back to the family doc, etc. If you want to make medication changes, they can change them. You can change the medications at that particular time, even with an electronic signature, as long as everybody is informed there and it's okay with everybody there. So your point is well taken. Yes, you can't pick up some of those things. And I don't like the video way back so that a person sitting back, because the most important thing is from here, for me. The facial is much more important than most of the other things, but I'm also in a private office. I'm watching the knee jiggling and the fidgeting and all that kind of stuff, shaking, and it can give me some clues as to medication side effects. So you're very right, and that's what we've done to correct it. Or that's what we're doing to address it.
It's a really interesting piece of research, though, to carry out a study, even with sham-type situations, actors, and see what could be picked up. There's really some exciting possibilities there.
Just kind of following up on that a little bit more, I'm just curious about kind of the usability, like how human-friendly the systems are, considering the wide range of people that you have involved with the systems, like from doctors to nurses to technical people to, like you had a chart up there with like whatever, a dozen different people being involved, like maybe more, and then the people on the remote side, you raise the issue of training and capacity building and all of that kind of stuff. Have you looked at that at all, or has that been kind of
Well, and that's a good point, and we have to look at capacity building, getting people to train, because so many people are involved. But what we want to do is train one person there that can look after that. So we find that the clinicians aren't so hot at going and turning the machines on, turning it off, collecting data, doing all that kind of things. So we ensure that someone is going to do that. So a master at getting everybody to do that is Terry, who's the manager, who has to deal with all the sites, make sure he collects all that data. Anything else, Terry, that you wanted to say about that?
I think if you go back to the CAP model, there has to be someone responsible both clinically, administratively, and technically. Now, sometimes those are very different people. Sometimes those individuals are the same person at each site. But you have to give them the knowledge base to be able to kind of troubleshoot at each level, or at least give them the wherewithal to hook up with someone if there is a problem rather expeditiously.
Ron?
I was kind of surprised that there was a comfort level both at the doctor's end and at the patient level. But if that is in fact true, then I started to think, well, why wouldn't that work with GPs and things? And that led me to think, well, how many times when you go into a doctor's office do you actually get pushed and prodded? I realized that not all that many times except for blood pressure, perhaps. So why couldn't you apply the same principle to home care through television or through computer?
Great point.
And if that is the case, then doesn't that widen the market area? And wouldn't that open up other areas that you might go to solve the problem of O3?
Absolutely. And I think if we start moving into community care, because we have some pilots, we've done a couple of pilots with the handheld computers and plugging into the telephone system, right? So that if we start doing that, there's still a little problem with the grade that's there, but I think it's the way we should go. And also with all the family docs. This is where it goes. There should be the 25, how many thousand there are, what are there, 50, 75,000 in Canada. This should be so that family docs can have access to a specialist at the time they see the person, so there wouldn't have to be a wait. So the same thing can happen in the urban centers as it does in the rural centers. And just to complete, before you answer, the other thing is, it's not so easy to get people to do it. The patients are the easiest person to get to do it. But you try to get some staff people to do that, especially the other end, because they're worried about how they look, how they're going to come across on the screen, different stuff like that. And it takes us a training time. And as you've seen on there, it can take us up to a year to get a clinic trained in a certain way.
But don't your own stats indicate that you have a greater number of visits, and doctors have, the greater the number of visits they get in, the more money they get from OHIP. So wouldn't that financial benefit tend to motivate them to adopt the system that would allow them to increase their income?
Well, right now, we're on a sessional fee. We're paying the docs on sessionals, or they're hired by the psychiatric hospital, so it's part of their salary. Some of the people we do pay by sessionals, but we're not paid by the number that they see. So that it doesn't work with these numbers that we've got here. Any other thought that you had, Terry? Did you have?
It's not a fee-for-service situation.
So one other thing occurs to me. Government, per se, from what I read, is trying to get people to take better care of themselves so they won't have to go to hospital and get the government to spend a whole lot of money. So they want you to stay healthy, and if you do get a little sick, they want you to take care of yourself at home.
Yeah.
Now, on the other hand, they're giving you money so you can learn, you can develop this new telemetry thing for literally practicing psychiatric medicine, which is applicable to practicing probably general medicine and other disciplines as well. Wouldn't further contribution to that tend to promote their own stated philosophy for home health care? Like, aren't they shooting themselves in the foot by cutting you off in 03?
Thank you. They are exactly doing that. So I think you're dead on.
Don't send stamps around.
Yeah.
Really, in some sense, Robbie, what you're saying is that what you could reduce encounters with the medical system or medical profession by collecting health indicators.
Yes.
You know, I mean, your heart beat, your pulse, your blood pressure, glucose measurement if you're worried about diabetes, etc. So this way, this is an economical way, and in fact, we hope to reduce those numbers of encounters and hence use expensive people.
That's right, and by earlier intervention, so you don't have the wait list. So you cut those down. The earlier you get in, the easier it is to treat someone, and you'll reduce the number of visits.
You also get a time series analysis of what's happening to people. There's a hell of a lot more information than you get by one encounter.
Yeah, good point.
I was talking to something earlier. You mentioned that there are only 3,000 psychiatrists in Canada. And for some of us, that could be good or bad. I'm not fewer than lawyers, right, Robbie? We work very closely with people.
We're not talking about good, bad, or indifference.
Our field right now is a lawyer who's part of this team, and we're extremely active in this area. I just wondered, how acceptable is this across those 3,000? I mean, would it be 50 who feel comfortable with this? All 3,000? How transportable is it?
Well, it's building. Basically, when we got started back in 1992, between 92 and 94, when we were developing it, there were very few people that even thought it was a possibility. Initially, when I presented to the London Psychiatric Hospital in 94, they felt that, well, this is fraught with too many problems, you can't do this. But now we're growing, and it's like any other market, I suppose. A third, approximately, are becoming accepting of it. A third are pretty skeptical at the other end, and a third that kind of are being persuaded. But I think now we have a consortium of psychiatrists with the 4 medical schools. And once you get the medical schools and coming from the chairman down, and you get a request from the community up, then the docs in the middle are starting to jump on board. And when they see they're not going to be sued for every interaction, then I think they're much more willing to get on board with it. And the CMPA more recently has allowed them to proceed a little bit further with that. But the other issue too, and that's where the computer science comes in, is that we have to address confidentiality and security issues. And this has been very big in psychiatry, as you know. That leakage of information and this kind of thing, privacy, this sort of thing has to be addressed. And the information can't go out, must be contained, because you can imagine what would happen if some of that information leaked out to the public.
Now, by the way, is there any thought of teaching any aspect of this in medical school or post-medical school education?
Well, we were fortunate enough to be able to have the first psychiatric resident or postgraduate in psychiatry. We had a teaching fellow for 1 year doing tele-psychiatry at Western. He is now up in Thunder Bay. So at least that's a stepping stone. So that's acknowledged. Right now, it hasn't crept into the compulsory curricula. However, University of Toronto and Western are sending students up north and being able to keep them in contact with their classes while they're doing locums or doing training with the docs up there. So they're already doing that right now. And so that's working out fairly well, because they can't send them up north for a month or two because they have to have that classroom time as well. This way they can do both.
Instead of giving them exam grades, will you give them Nielsen ratings or what?
Hey, this is good. Yes.
You're servicing two different populations, the First Nations and municipalities. You said, are there any perceived differences so far in acceptance of the technology or other differences that you can mention?
Yeah, I think we found that we have, one is a political kind of thing that we didn't really bank on would be as strong as it is. Felt that initially off the top that the First Nation people weren't a group of First Nations. And having them, it's like dealing with different cultures. So that's been kind of hard to try to coordinate that because everyone has their own agenda. The other thing that sort of, there was a perception that North Network was, you know, a competitor to this, and we were doing the psychiatry, they were doing the other things, and that sort of made them distrust us somehow, saying, well, who's this? Are we supposed to take this or that, or what are we supposed to be doing? The other thing is, too, is that we have included their native healers with this. So there's a difference in their approach. Their time schedule is different. I don't know if any of you have dealt with Aboriginal or Native people, and they seem to have a different time frame. So if you set the appointment for 10 o'clock, 11:30 is in the morning of the time you're supposed to be there. That doesn't work with this technology. However, when they get on board, they are on board and wish to have it. They're starting to move. They want to have control of their own health care. They don't wish us to be telling them what to do. So as long as we realize we have to allow each First Nation their own autonomy, and that we're dealing with a collective, 626 or something like that, First Nation groups in Canada, there are some collective groups that work together, but basically that's presented a problem. Also, it's a bit of a nightmare in trying to set up some form of uniform information system for them. There is an element of trust, I guess they keep going back to a whole bunch of other things that are unsettled with the government, and they bring things to the table that is beyond us, things that we're not certain of, and that impact and a risk to our project in trying to set them up that we're unaware of. So that's basically where we are with them.
Is there any issue with the recording? I'm asking the question, is it recorded, the actual session?
Yes, we record it. If we're looking at recording, like for forensics. So if you record it for forensics, and that's the place where it's used, it's been done. So you can record it also for teaching purposes. You have to make sure, we're suggesting that you have two forms. You have to have a Form 14, which allows you to share the information, but also a special, basically a little form that we've developed that would allow you to record it. So you can record it and store that information, so that you have to outline what the specific purpose is for. It's ideal for courtroom systems, and it is being used in the court systems right now. So
consent form?
Beg your pardon?
Or consent forms?
It's basically a consent form to store the information. But we have tried that and put that in, so we've had some... we're not doing it as a constant feature at the present time. The other thing that goes along with that, if you're in the room and you come up, you have to disclose if somebody else is in the room with you. That's a natural. So they at the other end have to know. So if you're with somebody, you have a student, you say, well, I have a student. Is it okay with you to, to have the student? No, I don't want nobody else in the room. That's fine. They can't do that. So you have to disclose that both ends.
I thought it would be helpful if it was allowable if you wanted to have a colleague of yours view a portion of the tape. You could sort of, send it through the web. I mean, if you could do something like that, I know that you mentioned there's some confidentiality,
yes,
privacy issues, but that may be an assistance in terms of the service you can provide.
Yeah, it might be, as long as that IP format is protected and you've got the intranet. Internet, of course, we can't put it across through the usual because it can be robbed too easily. So we're working through what can be transmitted, what can't be. Right now, the only thing we can put through the normal internet kind of system is education. So we can put that through there. Anything to do with patient record-keeping systems has to be a private, a VPN if you wish.
Encrypted, presumably?
And yes, encrypted, yeah.
Any other comments? I just want to ask Henry, go ahead.
With your evaluation criteria, you mentioned quality of care. What are you measuring?
Well, we're measuring a whole bunch of things. Jenny, you want to take a stab at answering the question?
Our quality of care that we're actually trying to do at the stage is our utilisation forms, trying to keep patients out of hospital because of and where that actually stands with our crisis intervention, medication management, whether or not patients being seen, it doesn't have to be for anything other than just how you go through the medication. That's the same.
I think
one of the other things too that is markedly different with the telehealth as opposed to an office visit is the amount of no-shows. When you go to a psychiatrist's office, lots and lots of no-shows. With our technology, the no-shows are greatly reduced. And even when the person doesn't show up, you still have the responsible caregiver there that can tell the psychiatrist at the treating end, this person didn't show up because of this, this, and this. The psychiatrist takes that all into account, tells the caregiver, well, why don't you try this, this, and this? And they're still getting care even though the patient isn't there.
Yeah. I think the other thing to add to that,
Exactly.
yeah, Don, the other thing is too, like with the questionnaires in terms of the quality of care, like satisfied with the interview, the psychiatrist, all that kind of stuff. Not only that, there are questions and stuff that they've been filling out and collecting with regard to the technical quality of care, the role of the technical component to the quality of care. So it's not just the clinician, it's the set, the setting, was it satisfactory, was the image clear, that kind of stuff. So we're collecting all that, we, Jenny and...
Just as an example, I can give you the one person that didn't like the service, had no insight, didn't think that they were sick anyway, didn't want to see a psychiatrist on the telly or anywhere else anyway. So that was the one negative comment that we did that with respect to those.
I appreciate your challenge, and actually it's very interesting that you're incorporating telehealth and all that sort of thing. But what in your partnerships, and we feel there's a huge partnership between that support both between private and public and within the healthcare continuum. What about your interactions with neurology, the neurology discipline? Are they up to speed with this with you? I know there's a large interaction between psychiatry and neurology.
Well, and there is, and good point. For instance, we're looking at through LHRI, which is Loss and Health Research Institute, we have a new EEG hat. So if we put the EEG hat on, the electrodes are connected. It's nice to have it right there, but to have a hat in a community makes it easy because then you can put and have it read right at the same time. That's the EEG component. When we're starting to look at MRIs and PET scans, we're just looking at that. And of course, if you move into the tools of the CT scanning, this kind of stuff, some of those tools, those radiology tools, require a whole bunch more bandwidth. So the bandwidth we require just for the video component is about 1 meg. For the data exchange is about 1 meg. So we're looking at trying to protect 2 meg of bandwidth into each site we go. If we start using those, we can use it all up in a hurry and use a lot more than that kind of thing. But I think your suggestion is great because there is a connection, especially with dealing with the trauma units, behavioral kind of stuff following trauma, as you're pointing out, all the different areas of trying to deal with depression and concurrent illness, especially in the neurological vein, dealing with the epilepsy kinds of things, all these things, concussion, post-concussive. There's a whole host of them. You're very right. Psychiatry is a stepping stone to a whole bunch of other things, of course. The reason I think that we're using psychiatry, well, I guess because I'm a psychiatrist, I've always been interested in it, but also I see it as a way to bring on all the other people on board. And one of those first people would be those people that are closely aligned to psychiatry. The other one, because we're going into First Nation group, of course, is looking at the whole area of diabetes. So we're looking at how do we extend diabetes and doing the blood monitoring, etc., and this kind of stuff to have the instant readout at this end. So that you've got the person that can read all that. You can have the lab data, yes, but you can have the readout and some of the other physical parameters.
Why that's sort of answering my question, because now you have to look at a push and pull technology that blends those two things. You know, what really should be pushed out to the provider or the case manager, and what should be pull technology for culling this information, and then the retention period on top of that. And what brings to my mind too is that this is just begging for a knowledge management piece that actually applies these rules and guards against, overuse or underuse of data transfer.
Excellent points.
Out of time. Any, you want to make a quick comment on
What's happening elsewhere in Canada? Is this the only project, or are there other projects here or south?
They have in psychiatry. In psychiatry, yeah.
Kind of thing.
This kind of thing. Well, with the CHIPP grants, they have 29. There are 29 of them altogether. 6 of them have to do with a record-keeping system. The other have to do with other kinds of things. But probably with us, probably about half of them are looking at services. Like there is a radiology one. There is some of these different ones going on. There's another psychiatry one that's in BC that's similar, but not quite the same. So there's a whole pile of information. And we're collecting data, all the outcome data that each of them are collecting, and CHIPP is trying to compile and put them all together. And they're trying to also look at the risk management components of all of them, trying to make some sense of all of them to make recommendations to go post-CHIPP.
It sounds like Mr. Krachin is trying to get himself a greater lever to help master the various jobs.
We are unfortunately run out of time. I now think of him as Robbie King live. And,
Thank you.
Well, thanks for coming out today, and I look forward to seeing you next month, May 22nd. So please come and see us at that time where we'll look into privacy and healthcare and new technology. Thanks once again.